here before. Good to see some new faces. We'll be doing these monthly luncheon forums. Every month the legislature is in session. So certainly for the first 6 months of the year, and then we'll take a break during the summer and we'll be back in September. For those of you that are legislative staffers, also be on the lookout for our legislative staff training program that we do in conjunction with the House and Senate Business Office. We'll be kicking that off here during the first couple of months moving forward. And as you know, we also have other programs at IPPSR, our Michigan Political Leadership Program, our Legislative Leadership Program as well. We just had most of the freshman class in for a 2-day workshop in December, and we'll be continuing to work with them and legislative leadership moving forward. I'd be remiss if I didn't introduce Dr. Mac Grossman, IPPSR Director, who leads a lot of these programs as well. One of the other programs that we partner with is our Health Issue Forum sessions. And that is a partnership with the support of the Michigan Health Endowment Fund, and as well as with the Center for Health and Research Transformation at the University of Michigan, who you'll be hearing from today on Medicaid. These are sessions that we do for members and staff of the health-related committees in the House and the Senate. So if you're involved in health policy issues as well, be looking for those notices moving forward. And with that, I get to introduce our guests today, our speakers. One of them's on my phone, so you'll have to. So I first want to introduce Dr. Tayo Moss. Dr. Moss serves as the Policy and Program Officer for the Michigan Health Fund, Michigan's largest health foundation, and he is dedicated to enhancing access to quality health and wellness programs. Tayo helps develop health initiatives in underserved communities and has distributed over $28 million in grant funding, while also directing the policy portfolio for the health fund. And as I noted, they are our funding partner and very appreciative of their support in this effort. Prior to his current role, Tayo served for the Michigan House as Legislative Director and Policy Advisor, focusing on health insurance and transportation. He currently sits on the Board of Directors for the Sparrow Health System Foundation and the Ingham Health Corporation. He has a PhD in kinesiology from Michigan State University and also a bachelor's from Ferris State University, where he was captain on the football team.
Go Dogs!
National champions again. Right.
Go Bulldogs.
Also with us is Nancy Baum. Nancy is Director of Health Policy at the Center for Health and Research Transformation. She leads CHART's work developing and managing health policy projects and access to health care, local public health, claims data analysis, long-term supports and services, and behavioral health. Nancy herself has deep expertise in mental health and substance abuse services issues, workforce challenges, and innovations. She manages a team of excellent analysts working on a wide variety of health projects. Nancy earned her PhD from the Department of Health Management and Policy at the University of Michigan School of Public Health, and her master's from Johns Hopkins Bloomberg School of Public Health. She served as a board member for the Washtenaw Community Health Organization from 2013 to 2015. Melissa Riba is Director of Research and Evaluation at CHART. I touched it. There we go. Melissa is Director of Research and Evaluation in CHART, with more than 20 years of experience conducting applied research to inform policy and program improvements. She's also skilled in stakeholder engagement and collaborative research partnerships. Her own areas of expertise include behavioral and healthcare integration, maternal and reproductive health, social determinants of health, and health equity. As lead for CHART's research and evaluation team, Melissa directs key projects as well. In 2009, Melissa began CHART's first statewide survey of healthcare consumers. In addition to her role at CHART, Melissa is a lecturer within the U of M School of Public Health, where she teaches a course on health policy and advocacy, in addition to numerous guest lectures. She currently serves on the Ingham County Racial Equity Task Force, as well as the Housing Trust Fund. So as you can see, we have some wonderful talent that we're able to put forth in this program. I'm very pleased to partner with them, and let's welcome them to our session today.
Thank you, Arnold. Good afternoon. How's everyone doing? I just want to say thank you for the opportunity to be here. My name is Tayo. I work for the Michigan Health Endowment Fund. In regards to Medicaid, a big priority of us is reducing the cost of healthcare, and Medicaid in general is a big priority of ours as well. So happy to speak a little bit on what we do and collaborate. So really quickly, I like to have this question because it's kind of a good way to kind of get the conversation going and just talk about nonprofits and just about the philanthropy in general, which the Health Fund is really involved with. So really quickly, amongst your table, how many different types of nonprofits do you think are in the landscape of Michigan? All right, go ahead and talk to your table. All right, how many different types of nonprofit? What do we think? I heard six. I heard six over here.
Is that good? Higher, lower?
Maybe a tad higher. All right, let's all come back. All right, what are some guesses? Well, how many different nonprofit designations do we have? What do we think? We had 7 over here. What do we think? Any higher, lower? 10? 50, okay, let's see. There are 27 different types of nonprofit designations. What do we mean by that? Social advocacy groups, foundations, civil league, trade and professional associations, fraternity societies, employee beneficiary associations, veteran organizations, etc. So thank you very much for participating in that. So just a little bit about the Health Fund and who we are. As I mentioned before, our mission is to improve the cost or improve the health of Michigan residents, whether it's the special emphasis on the health and wellness of children and seniors specifically. Those are our priority populations, so we do make an impact on the lifespan of humans. And so the main point of the Health Fund is reducing costs of healthcare. And we were established by the legislature, actually. So we're a healthcare conversion foundation, and we were created by the legislature in 2014. And in 2023, our annual grant making was $23 million. So that's around how much we give out per year. And beyond our grant making, we do partnership and collaboration, capacity building for nonprofits, and also engaging and informing leaders in the policy space. And I'll talk about that in a little bit. Now, so just a little difference. I mentioned that we were created by the legislature in 2013, and where our funds come from, we're a healthcare conversion foundation, and Blue Cross Blue Shield essentially needs to give out $1.56 billion over 18 years to our endowment that will be around in perpetuity because of that. We have a 9-member board. We were appointed by the governor, and kind of just some background. We went on a listening tour in 2014-15, kind of go around the state to figure out what are some things that we need to focus on in the Health Fund? What are some priority areas in relation to health and wellness that may be good for all of Michigan residents? And then in 2017 and 18, we kind of embarked on our first cycle of grant making and really making an impact in the state and being on the ground floor, helping implement wellness programs throughout the state. Now, as for our 2025 goals, we would like to increase access to services, whether that be mental health services, Medicaid services, insurance services, behavioral health, physical activity, bridge health equity gaps, advanced integrated care, share knowledge and learning, and increase efficacy and costs, and also support the healthcare workforce, as we know is in a dire need in our state. And so what I would like to do before I turn it over to Chart is I would like to kind of provide just some overview about our grant making in the state. And I would love to maybe have this benefit your state reps in case they have any philanthropic organizations, municipalities, or any organizations that may benefit from our grant making dollars that we do here at the Health Fund. So the first one is behavioral health, and this grant range is up to $500,000, and the application is usually open in February, so that's just a plug that we have our behavioral health grant round opening very shortly. And in regards to this space, it's very important for us, as I mentioned earlier, improving access to high-quality mental health and substance abuse disorder treatment. So if you have any organizations that you work with in your communities as a staffer, if you have any organizations that do mental health services or would like to help your residents access types of resident behavioral health resources, please let me know. I'll be happy to connect. Next, nutrition and healthy lifestyles. The grant round is up to $500,000, and this grant round also opens up in March. And this is one that I'm very passionate about as well. And so really we're very cautious about improving food systems, alleviating barriers to healthy eating, and really promoting opportunities to engage in physical activity. So this is just another opportunity for us to partner with the communities that you serve. And I also mentioned earlier, we don't just fund nonprofits and philanthropy, we also fund school districts, we also fund hospital systems. Any entity besides a for-profit corporation, we can support. So I'm happy to engage in any conversation or partner with any other community-based organizations or municipalities that you support. Next, healthy aging. Also $500,000, and that's opens up in April. And this is really to improve the quality, coordination, and care of not only older adults, but caregivers as well. You know, I just wanted to go into a short story. This means a lot to my heart that we're supporting healthy aging too, and this relates to Medicare as well, is that, you know, we all have, you know, for instance, my grandfather had Alzheimer's, and kind of knowing that we're able to support the caregivers who are helping people that have dementia. I mean, we're all impacted in somehow. Helping people that have dementia or these kind of resources, it really hits home to me that we're able to provide this type of support. Maternal and infant health, this is $200,000. This grant round opens in December, so we just finished this cycle, but we'd be happy to engage in conversations for next year and reducing really disparities, increasing access and care for maternal and infant health population as well. And this is for our smaller grant rounds as well, so smaller community-based organizations that you serve. So if you have small nonprofits or very small community-based organizations that would like to enhance their capacity for their work, this type of grant will help support their capacity as well. So really supporting bold ideas that empower these smaller communities, really try and tackle health changes, and Medicare is definitely part of that as well. So that was really high level of the various programs that we offer as the Health Fund. But before I move into our legislative education that we're partnering with IPPSR and CHART, does anyone have any questions or would like to kind of talk a little bit about the work that they're doing in their community or any community-based organizations that would like to kind of partner with us? Does anyone have any thoughts or questions or comments? Yes, sir.
Tobacco reduction grants, what section would that go under?
That would go under nutrition and healthy lifestyles, Bill.
Thank you.
Yes, sir. Yes, ma'am.
What about work with our unhoused community?
So we don't go into that space a lot, but we're working towards it because homelessness is definitely an issue, and we would like to get more in that space in the future. And we're also going through a new strategic plan, and that may be something that we would like to maybe input in that. So definitely happy to engage in further conversations in that. Yes, sir.
How does DEI factor into your programming, your strategic plan, your funding?
Yes, so in regards to DEI, we do have a DEI component, but most of our work in regards is disparities, historical inequities. The communities that were impacted, have they experienced historical inequities and having access to physical activity opportunities, having access to behavioral health services? Is it a low SES area or low social economic status? All these considerations are factored in when we're making these grants. Making sure people who actually need it or are communities that if they experience these disparities are getting the help that they need in regards to grant dollars.
Is healthcare access a consideration?
100%, yes, sir. Yes, ma'am.
What about like criminal justice reform, whether it's like workforce development, like substance abuse? Which category would that fall?
That would go under behavioral health.
Okay.
So that grant round is coming right up, so happy to engage in a conversation.
Thank you.
Anyone else? Okay, thank you very much for that. So really moving on, and the piece I really wanted to hone in today is, since we're Michigan's biggest health foundation, we think it's important to help educate legislators and staff on a variety of health policy issues that are important to the state and important to you. And so I mentioned this before, that since 2020, we've really partnered with IPPSR and CHART to establish a collaborative framework for House and Senate members overseeing health policy matters. And this really initiative includes briefs and discussion forums on critical and timely health policy issues. And these are the various topics that we had before: mental health, substance abuse, healthcare workforce, healthcare costs, transparency, and resources for older adults. And what we've done in the past is we've developed briefs, we've had sessions to really try and collaborate and have a bipartisan event where we can come together and work on how to move the field forward in regards to health policy matters. And we really wanted to build on the success of that. So some of you may have attended, but we had our inaugural kind of health policy forum in spring of last year. And our topics were behavioral health and healthcare workforce. We had some great presenters from state agencies and various other organizations come in and present on the event. And what was so important about this is we really fostered kind of a bipartisan collaboration on really how we can move the needle forward in regards to healthcare workforce and behavioral health. And we really would like to continue and build on that for years to come. And what's next? What's on the portfolio for us in this collaboration? Well, we're planning our next session in the coming months, and Medicaid 101 may be part of that. And so we're very much looking forward to having another wonderful event for staff and legislators to come together and kind of move the needle forward in this type of work. So, and I mentioned that we're going to continue to focus on actual solutions and partnership opportunities, bipartisan partnership opportunities to move this work forward. So that's all I have before I move it to my colleague, Melissa, but thank you very much for your time and the opportunity to present today, and happy to answer any more questions before I move on. So, thank you.
Good afternoon. How's lunch? Good. It smells good. I can't wait to dig in when I'm done. I can't eat right before a presentation, so hope y'all left us some. All right. Let's see if I can figure out how to work the technology. There we are. All right. So here's the main event, talking about Michigan Medicaid. We're calling it a 101 because what the intention of sessions like this is to provide just, some basic facts and introduce some policy considerations, things that might, be talked about in the coming legislative year. And so what we want to do is just sort of provide a primer, and that's kind of a nice blatant tie-in to the work we've done, which I'll connect you all to before, at the end. We have an actual primer that is available online, and so you can download it and use it and refer to it. But yeah, so why do we want to talk about Medicaid? What's the big deal about Medicaid? Medicaid is a huge, huge part of the healthcare landscape in Michigan. Any guesses, okay? What proportion of Michiganders are covered by Medicaid? And just shout it out. 1.7. There's some good diversity. It's about 1/4, about 25% in total. Okay, that includes adults and children. Children are about 45% of Medicaid beneficiaries, and so that's really big. Okay, it's about 2.3 million Michiganders in total, and almost 1 million kids. Okay, now to put that into context, right, and to give a visual. And I know I'm in sort of Spartan territory a little bit here, and people are from maybe all over, but full disclosure, Arnold didn't give my credentials. I am a Spartan, so go green. Got to do that, sorry to my Michigan colleagues. But anyway, we all know about the big house, right, Michigan Stadium, capacity of about 100,000 spectators, right? So if you were to put everyone who is on and receiving benefits through Michigan Medicaid into almost at Spartan Stadium, into the big house, it would be 20 big houses, give or take. If you were to put all the children, all the kids and youth who are covered through Michigan Medicaid into a big house, you would need about 9 or 10 big houses to house that many people. So that's, I find that helpful just to have kind of a visual of how impactful this program is. It's a big deal. And it's important. And when we talk about things like cost, coverage, insurance, uninsurance, it is a big player in in helping access and some of the discussions I think that'll be coming up in the coming year with the new federal administration coming in are going to be, I think, very much centered on cost and cuts and spending and those pieces. But let's start with, I already kind of stepped on this a little bit, stepped on my lead a little bit here, but yeah, so eligibility enrollment, who's covered, I already talked about kind of the magnitude and penetration. Medicaid is, as I think most people know, it's based on income. Eligibility is mostly based on income. The current threshold is 138% of federal poverty level, and that amounts to about $20,000 per year for a single individual, or about $35,000 for a family of 3. Okay, so that's just to give some context. There are other, what we call categorical eligibilities. So these are folks who maybe are above the federal poverty threshold, but because of their categorical eligibility, what we call the eligibility requirements, it could be pregnant women, disabled, the aged, elderly, and those receiving long-term services. So again, it's not just a poverty program necessarily. It's covering a lot of folks, like especially disabled individuals and the elderly, and playing an important role. As Tayo mentioned, one of the things that Michigan Medicaid and Medicaid programs do nationally, as well as within the state, are to provide support for long-term services and support for our older citizens. And so it enables things like aging in place and other kinds of services and supports. So kind of a snapshot there. What is covered? So Medicaid is a federal-state partnership, right? It's run and administered by each state, but it's done in partnership with the federal government. To that end, every state has to have a state plan with the federal government that says this is what we're going to do, this is what we're going to cover, and the federal government has to sign off on that plan. Okay, and that's the basic starting point, I guess you could say. There's a federal requirement that all states have to, if you're doing Medicaid, which all states do, there's a minimum threshold of the kinds of services that absolutely have to be covered, and that's all listed there: hospital, physician, labs, ambulance, family planning, and home health services, again tying back into kind of the services and supports for aging in place. For children, there's an added requirement related to periodic screening for both cognitive, developmental, mental health, dental, and this is aimed at prevention, right? Because what we know from the evidence is that if you can catch conditions or problems early on in a person's life, it can be more easily addressed and maybe avoid more costly care and needs further down the road, okay? Now, within that, there are other requirements, but each state has the ability to tailor their Medicaid program to the needs of their specific population, as well as the priorities that each state decides that this is what we want to work on, this is what we want to provide. Within Michigan, the optional coverages are the things that are outside of those federally required pieces are dental, vision, hospice, chiropractic, and more recently has been added, I think it was just in the last year-ish, doula services, yeah, year-ish. Doula services, as well as expanded behavioral health and social needs, addressing social needs as part of social determinants of health. Okay, talked about long-term services and supports are a big piece of what is provided to you through Medicaid to the older populations. We have, these are things like, there's sort of two big buckets here under this broad umbrella of long-term services and supports. One is the kind of the conventional thing we think of like nursing homes, right? Nursing home institutional care. There's also another bucket of this that is home and community-based services, right? So this is the aging in place kind of policies and things. Because what we know is that nursing homes are probably the most costly way to care for our older adults, right? and they don't always have the best outcomes. You know, even the highest quality places, they're institutions, right? I mean, for the most part. So the idea is that it's better if we can, it's more cost effective, it's just better, it's a best practice really, to be able to provide services and supports to keep people aging in their home. And that can include things like delivering the care in the home, so nursing services, physical therapy, occupational therapy, the kinds of things that an older adult might need to help recover from an illness or to address a chronic and ongoing condition. It can also be personal care, right? So what we call activities of daily living, right? Cooking, cleaning, getting dressed, very basic things that can help them. And then there's a whole host of other things that are really aimed at putting the services in the home and helping our older adults kind of thrive and age in place as best they can. Okay, and then direct care workers. You just want to?
No, I was just going to highlight a couple specific programs that are really fantastic that Medicaid covers that provide services in the home. So one that you may have heard of called PACE. So this is a service where somebody who is eligible for a nursing home level of care but would really prefer to stay at home. The service is from practically sunrise to sunset. They get picked up on a bus if they're home. They're taken to the PACE Center where they get all their meals. They get their health care services delivered there. They have their laundry done. They can have therapy services. And then at the end of this long supported day, the bus takes them home and they can stay at home overnight. So that's one example. Another example is a program called Home Help, where people can actually hire whoever they want to help them in their homes, including relatives. And Medicaid pays low but hourly wage to that individual who comes into their home and helps them. And that person who needs services gets to choose that caregiver. So, and there are a variety of other programs like that that Medicaid covers, but they're really important. And I think a lot of people think Medicare covers these kinds of services because Medicare really covers the elderly. But in fact, it's Medicaid that pays for all of those services.
Oh, good points, thank you. The other piece I would highlight here, and this is true of healthcare in general, but there's a workforce shortage in healthcare kind of, writ large. But when you get into certain areas, particularly related to long-term services and supports, direct care workers, this is, these are like nursing aides and personal care aides. These are the folks who would come in and deliver this care in the home and help our older loved ones. And it's been plagued, I think, as Nancy sort of alluded to there, that it's not high pay, right? There's real problems with recruitment, retention, keeping people in these positions, turnover. And so to start to address that, we've seen the legislature has increased pay rates for this specific group of workers to try to at least begin to address the shortage. But this is, so many areas of healthcare are plagued by workforce shortages. So it's definitely an ongoing issue. I mentioned before that there is flexibility, right? So the federal government says these are the things states must do, must cover. But there's also flexibility, okay? There's a couple ways this is done. One is largely through waivers. You might hear, something called an 1115 waiver is kind of the shorthand for this. These are what we call sort of demonstration waivers. So this is if the state wants to do something that varies from their approved plan in some way, like you want to cover, provide Medicaid services for justice-involved population, okay, or justice involved, but reentry into communities, and you want to specifically focus on populations in that area. You might decide that an 1115 waiver is the way to do this. It's also called demonstration waiver. The reason for this is that it has a requirement. It's not necessarily It's not like just, can we do this, please, right? And then, yes, no. There's a whole process, but it's a 5-year demonstration project. You make the case for, the state needs to make the case for why this is needed. It's time limited, so it's 5 years. There's a possibility of an extension for, possible another 5 years. There's also a requirement for a fairly robust evaluation, right, in the spirit of demonstration. So what the federal government wants to know is, if we let you do this, is it going to work? How is it working? Probably the biggest example I can think of is Michigan's Medicaid expansion plan, the Healthy Michigan Plan. That was, among other things, initially started from an 1115 demonstration waiver back in 2013. It was extended again in 2018. Okay, and that's one of the tools or levers by which we had an expanded Medicaid program in the state. Another way that changes or flexibility can be built in is, you might hear people talk about a SPA, people in health policy. We love acronyms. Acronyms. It's a SPA, and it's not like go get a massage spa. It's ask the federal government, can we amend our state plan through a pretty arduous process of justifying why the changes are needed into the plan. And so you can expand, again, just like with a waiver, you can expand the scope of services, you can expand populations, okay? But again, it has to be approved by the federal government, first and foremost. And as of July, Michigan Medicaid has about 10 approved waivers that I think are still ongoing. I think all of these, and those are just some examples there that are related to the waivers, where you see expanded populations and services. Okay. Funding. Okay, this is the big one, right? The money question. I mentioned federal-state partnership. There's something called the, again, acronym alert, FMAP, right? Federal Medical Assistance Program. The other thing I love about healthcare acronyms is when you say it out, it often doesn't necessarily make a lot of sense for what it is. It just doesn't necessarily track that, but it's the match. Basically, it's what we might shorthand and call it a match, but it's the FMAP, and that's the share that Medicaid provides. Medicaid, the federal government provides about covers about two-thirds of state Medicaid funding, and then the state of Michigan provides the other third. That comes out of general fund budget. So that's what we call the FMAP. It ranges nationally. There's a whole set of criteria that states use to justify and rationale for the different levels of funding. Michigan's at about 65%. So we're not the lowest, we're right in the middle, okay? I think Mississippi is perhaps has the highest level of funding, and they're in the 80s, 83% FMAP. So that's the money that the federal government matches or reimburses the state for running the program. And again, it varies. This is important as we think ahead towards what the incoming federal administration, some of the policy changes that they might be looking to make. So it's important to understand FMAP in particular. What else do I want to say? Yeah, I talked about the federal Medicaid expansion. So for the Healthy Michigan Plan, because it's under the expansion, that is, the FMAP there is at an elevated rate, it's at 90%. So the expansion population is reimbursed at a higher match rate than the, quote, regular Medicaid or traditional Medicaid. Okay. We talked about general fund. Okay. Affordable Care Act. We've touched a little bit on this with talking about Healthy Michigan. So, ACA, just a quick overview. ACA was passed in 2010, 2012. Okay, the original ACA included a quote mandate, right, that states had to expand Medicaid. Supreme Court ruled in 2012. No, they don't have to. It can be optional, right? So Michigan was really at the forefront of expanding Medicaid. So in 2014 did so. And we've had the Healthy Michigan Plan ever since. We were actually, again, at the forefront of this. I think as of right now, 41 states have an expanded Medicaid program. So it's most states, I believe. Yeah, so what changed there? All Michiganders are eligible based on income. It used to be that pre-ACA, it was all based on mostly categorical eligibility. So this was extended to all Michiganders based on income. And then, you no longer needed that categorical. So what that did was bring in a lot more single adults who might not otherwise have been able to qualify for Medicaid coverage. One of the biggest impacts is on the uninsurance rate. Okay, it's kind of a no-brainer, right? You increase access to insurance, it's gonna reduce the uninsurance rate, and obviously that is what we see. It's basically cut uninsurance in half in Michigan. Prior to the ACA, it was hovering around 12%. And then now it's about, anywhere from 4 to 5%, depending on what you look, what years you look at. And then, because this was a demonstration project, there was a requirement that there was a robust evaluation be conducted. Our colleagues at University of Michigan Institute for Health Policy and Innovation have conducted that evaluation, and they've found fairly positive results in many of the domains. One of the big ones, again, if we're talking about cost, and this has implications as we talk about different policy options, is that they also show reduced uncompensated care for hospitals across the state. And that's really important because there's a federal law called EMTALA, and I don't know, I can't tell you what that acronym is, so what it stands for, Emergency and Treatment. Yeah, fill in your acronym. We could do a whole icebreaker about just make up an acronym, right? But anyway, but basically, long story short, what that, if you're not familiar with it, the overly simplified explanation of it is that hospitals have to treat and stabilize anybody who shows up in their ED, right, regardless of insurance status. Well, what that means is that if people don't have insurance, and they don't have a means to pay, it can result in what we call uncompensated care for hospitals, which can, in various ways, harm their bottom line. So that's important too, as we think about some of the different policy changes that might be under consideration, is that uncompensated care. Okay. All right. How is Michigan different? Michigan is very special. We really are. It's a fantastic state. We've done a lot of really, really innovative things. And I get really excited because, I'm a health policy and data geek, right? So I'm like, this is exciting stuff. And I know you guys are like, yeah, okay. But, we have some really innovative things that put us at the forefront. One of the things that Michigan has really been at the forefront in is the way we've used managed care, okay? For those of you not familiar with the terms about managed care or managed care structure, basically what that means is that a health plan will be given a, quote, capitated amount. It's a fixed amount, right, capitation. You're going to get $1,000 per member per month, right? And you've got to use that to provide all the care. That's all you get, right? The idea for that is that it incentivizes being efficient, providing high quality care using evidence-based procedures and treatments, but also to kind of innovate and focus on chronic care, chronic conditions, things that could cause somebody to end up in an ED, right? When maybe someone can have their diabetes or their high blood pressure well managed through a care relationship. It keeps them maybe out of the hospital, right? So that saves a little bit of money. So it's an idea that it incentivizes plans to work better and harder, right, and do more. And so Michigan's been at the forefront of this. I think we have, I can't remember how many
Medicaid health plans.
6, 9?
Oh, more, yeah, maybe 11.
11, yeah. But, the important number there is nearly 2 million of our beneficiaries are being served through a managed care organization, or what we call a Medicaid health plan, okay? So this is something that is pretty prevalent here, and it is really, kind of at the forefront. We started doing this in 1996, so we're going on, 30 years. Yeah, 30 years, make me feel old. So managed care. The other piece that makes Michigan unique is we have what we call a behavioral health carve-out. What that means is that we basically have two sort of parallel systems for providing behavioral health care in the state. So for what we call mild to moderate diagnoses, it's based on a diagnosis largely. So for mild to moderate, so if you think about it, you know, Nancy, my health expert here, is going to cringe when I say it's like, you know, if you think about depression, anxiety, right? That's typically what we might consider mild to moderate. Those folks tend to get treated within their Medicaid health plan, right? They can, you know, they don't have to go to a different system. For those who have a diagnosis of severe mental illness or impairment, for youth it's severe emotional disturbance, intellectual or developmental disabilities, and also substance use disorders. Those get treated in this different system that is served by a system of prepaid inpatient health plans, or PIHPs, and community mental health service providers. Okay? So that's a different parallel system that and PIHPs are sort of like the administrator and payer for that system, and they work with the CMSPs by diagnosis. Okay, so it's kind of bifurcated and different. In recent years, you know, within the last 3-5 years, this is before
298?
298. Yeah, was this before COVID?
Yeah.
I don't know about you all, but I mark everything like pre-COVID, post-COVID, you know, okay. It's not pre-COVID, that was like in the olden times. And, yeah, so before COVID, there was something called, and you might hear this, the 298 effort, which was to try to carve back in and bring those systems together. Predictably, the PIHPs and CMHs did not like that, right? Because that would take money away from them, presumably, and change the system. The Medicaid health plans were like, yes, we like that. We'll get that money. So, you know, and it's not quite as simple as that, but again, you know, unfortunately, I don't want to sound cynical, but a lot of healthcare has followed the money. So,
Can I just add a little context? That public behavioral health system is around $3.5 billion a year in Michigan. So it's a lot of money. And the health plans are interested in part because it's a lot of money. And they would like to have those dollars come to the health plans. The reason that we have this carved out system is because there are very, very specialized providers who treat people with schizophrenia and people with major depressive disorder and some of these issues. And so the providers that Medicaid health plans contract with don't necessarily have experience with that population. So you can see why this was for advocates and people who are receiving these services. This was a very big and very important discussion. It was raised a number of years ago, as Melissa said, from some language from some budget language that basically said, explore this idea. And so the idea was explored very seriously for quite a few years, was very contentious, and now has gone quiet for a while.
yeah. I mean, yeah, I reduced it to money, but it's a lot. It's a lot. I mean, the specialty, very deeply specialty care that occurs in the CMH and PHP systems. So behavioral health. So those are kind of the two pieces that make Michigan unique. What are our challenges? I don't think this is necessarily unique to Michigan, but you know, we have something called churn. You might hear about churn. Churn is just because of the nature of how people become eligible for Medicaid, and because of the requirements after the public health emergency for redeterminations, right? Because every, is it on a yearly basis here in Michigan, they have to be redetermined to be eligible. So because of that, if someone's determined ineligible, they churn, okay? They might go off. It can happen, quite often due to administrative or procedural things, really. Sometimes it is because people are no longer eligible because of, the categorical reason they qualified or their income. But sometimes, and more often than not, it's often because of a procedural thing, like they didn't get the piece of mail. They don't have access to the internet, so they don't, they're on email. Or they didn't have the right documentation, or they missed a deadline, right? I mean, so these are kind of some of the reasons too. And so one of the things that has been looked at, and this is something too that the federal government has done under the Biden administration, is to look at lengthening the eligibility period. So, instead of doing monthly or quarterly or whatever, 1 year cycles. Also having what we call ex parte renewals, which is just basically automatic renewals. So it's kind of a presumptive eligibility and re-enrollment, and then it's confirmed. But that way it avoids people who are otherwise eligible being kicked off. And the problem with kicking, people losing insurance is that they might delay care, they might not seek care, they might be in the middle of care but have to discontinue some kind of care for a chronic condition. So these are the kinds of things that we want to minimize and reduce if at all possible. Okay. Increases costs. This is like the evergreen thing in healthcare. I mean, it's not unique to Michigan. The biggest thing to keep in mind about Medicaid is it's what we call counter-cyclical. So demand for Medicaid goes up when the economy goes down. And so, it increases demand, people lose jobs. In Michigan, more than, what's the proportion of employer sponsored? Is it like 70%? 50 to 70%?
It's a lot.
It's a lot. Let's just say a lot. Get our insurance through our employers, right? So if the economy downturns and you lose your job, you also unfortunately not only lose your income, but you lose your insurance, okay? And so, these things are kind of, cyclical in that sense. Different subgroups, have different cost to them based on the complexity. Children tend to be lower cost. Dual eligibles, these are like the older adults, and when we say dual eligibles, those are the Medicaid plus Medicare individuals. Those tend to be disabled, older, elderly residents. So those can be, some of the things that impact costs. The other big thing is provider reimbursement tends to be very low. Okay, and Michigan it varies depending on the service, the provider. There's a different rate schedules, but it tends to be low, which is a disincentive for providers to want to participate in Medicaid. I've had conversations with providers, physicians, office managers, and health system administrators, and they literally do a calculation of what proportion of Medicaid can they have in their payer mix and still break even or make a profit, right? Because we're, healthcare's profit. So these are calculations, and that's because of the low payer mix. When you hear about, sometimes you'll hear about these secret shopper studies sometimes, where someone will do a study and call around to see if they have, I have Medicaid, can I be seen? And we find lower proportions of individuals with Medicaid being able to get an appointment with some providers, and that's one of the reasons, is because that calculation and the low provider rates, and that's an issue. It's a very big issue. Okay. Very quickly, public health emergency unwind. This started in April of 2024. This is during the pandemic. Many rules related to public health were either delayed or suspended. The biggest one related to Medicaid was the requirement to redetermine eligibility. So what happened was Medicaid in Michigan and all the states where someone was eligible for Medicaid, they stayed eligible for Medicaid until the public health emergency was declared ended, which again, that started in April. And we call it unwinding because I think it's a very apt kind of metaphor for the kinds of things that have to be done, because it's not just, okay, stop, flip a switch, and people are covered or not. It's a huge procedural hurdle, very complex to reenact and reinstate these kinds of things. And the concern, of course, is that people lose coverage, right? So as this continues, and again, as I said, some people do lose coverage because they don't qualify, but some it's procedural. So again, and that is ongoing. Even though it started in April of 2024, it's still an ongoing process that they're refining and trying to improve. All right. So Last slide, you know, in case you've been living in a cave for the last, 3-4 months or a year, we will have a new federal administration coming in just, 4 days on Monday. And so while we don't have anything on the table, nothing has been passed, what we do know from the previous Trump administration, and also things that have already been kind of put out there, floated out there, talked about, is that, we can expect to see significant changes. And most of those changes are going to come in the form of cuts to spending from the federal government, okay? Which then, remember, because it's a partnership, that trickles down to the state. And what that means is that it's going to be incumbent on the state, on, state legislators, on, on staffers, on all the people working in government and policy to come up with ways to manage these changes. And, hopefully do so in a way that holds as many people harmless as possible, right? So those are just some of the things that have been kind of floated out there. Nothing is, set in stone, but these are things that I think most of, Medicaid officials around the country are anticipating. There's a lot there. You could do a whole talk just on these things. I think some of the most important ones, the FMAP, I mentioned that. Okay, so the floor is at 50%, so that's the minimum that states can expect. If the federal government decides to lower that, that can, we're talking billions of dollars, so even just changing by 1% can result in $1 billion reduction for states. So that's one that I know Medicaid directors around the country are really nervous about and watching. Work requirements, that's another big one that we saw in the first Trump administration. Michigan Medicaid had that previously, but then it was unimplemented or not implemented or paused during COVID. And then I think, those are just some things. I'm happy to answer questions or talk about any of that. I don't know, Nancy, do you want to chime in on any of those?
I think just the other thing that you hear a lot about is instead of Medicaid being an entitlement program, meaning anyone who qualifies can be covered, there may be a lot of conversation about instead offering block grants to a state and saying, it's not going to be anybody who covered and enrolled and that's how much the federal government will match. Instead, it will be, for this year, here's the amount of money that the federal government will give to the state of Michigan, and the state of Michigan will have to work within that limit. So they call that a block grant, and we have block grants for many other issues like mental health and others, that some of which work very well and that states have been using forever. And similarly, this idea that maybe a per capita cap, instead of matching everything that's spent at 65%, the federal government might say, here's the amount that we're going to provide per person who qualifies for Medicaid. So I think those are the main ones. There's a lot of, as Melissa said, it's speculation, of course, at this point, but these are topics that either have been raised before or have been raised recently among policy blocks.
And I'll just highlight the latest document I saw just related to Medicaid. So this is just Medicaid, 2.3 trillion. Like I remember when a million seemed like a lot, right? But now we're talking trillion. So that's sort of what's being floated out there. I think, the end result, is that it shifts greater pressure to the states, because then what that does, it saves money for the federal government, not necessarily for states, and so states might have less to work with, so then it puts the financial pressure to manage that well and manage the risk, because it's all on you. So if you do like a block grant or per capita cap, it's like that managed care capitation formula. If you do well, you might be okay and actually realize savings. If not, you might end up in a deficit. So I think that's kind of the point I would underscore, is that if these cuts, some of these spending things go through, it's going to shift greater responsibility and pressure to the states. Okay, and then just highlight, I'll take questions, but just want to highlight our primer. So that's there. And we're also happy to, you want to reach out for any questions after this or resources. So yeah.
Yeah, just real quickly, I know this was a broad overview of everything, and it was very interesting. Is there just in like a couple words that you can share that would tell somebody if they feel like they need Medicaid services, where do they start?
I would go to my local health department.
Okay.
There are many other places that qualify people for and enroll people in Medicaid,
Okay.
but the health department is one of the main ones.
Great, thank you.
Aside from the need that's out there, in the event some of these things happen, right? And how the state will respond. Aside from the need, does the multiplier effect of the expenditure feed into the calculation of the decisions that will be made as how to respond?
You mean within the state?
Yes.
I'm not sure I understood the
Yeah, the
question.
multiplier effect, can you explain
The
that?
dollars are spent in the community,
Oh.
and that creates economic impact. And I'm asking if those federal or state dollars spent are factored into the need to continue the program, as compared to other industries where the multiplier effect, where it's not a labor-intensive market, provider services, the money doesn't circulate as much.
I mean, I think that's a good point. I think that certainly does get brought up in some of the, policy. That's sort of where the policy conversations happen, like that downstream effect. It's not just if we cut this program, that's it, right? And think about the example of uncompensated care. So if less people have coverage and your uninsurance rate goes up, you could see that trickle down into greater uncompensated care, for example, right? So I think that's part of the policy conversation. I can't speak to how much it actually plays into what actually gets implemented, but I know those are things I heard raised in some of the discussions.
You mentioned the low reimbursement rate. I've read in some parts of the country that many people, particularly on the borderline in the poverty program, want to turn down Medicaid. In other words, they're borderline eligible, but they don't want it because they'd rather have health insurance, particularly subsidized through the Affordable Care Act. But some states are denying people the right to use the Affordable Care Act if they turn down Medicaid. Can you comment on that as it relates to Michigan?
I think that you're talking about the marketplace and
Yeah.
how the marketplace works.
Right.
And I think the idea is that you can't both be eligible for Medicaid and go to the marketplace and get subsidized coverage. I think that's right.
But if they turn down Medicaid, they're caught in a bind where they can't get either?
I think that if you're eligible for Medicaid,
Yeah.
you can't say, no, thank you, I'd rather have subsidized private health insurance. I think
Right.
that's correct.
I first just want to thank you for giving us all that information. It was great. But I am a staffer in a legislator's office, and I have gotten concerns from constituents in regards to the turning off sometimes of the Medicaid. And I saw that you did say that there has been improvement in having it automatically renewed for certain cases. Do you know if that's case by case on if it can be automatically removed? Do they have to request to say, I don't want to have to submit every 3 months to re-verify, my different health conditions and things? So what do you recommend I let constituents know what to do to have it automatically reissued, I guess?
Yeah, so to my knowledge, the vast majority of people who are covered by Medicaid have to be assessed for eligibility once a year in Michigan. It's different in different states, but in Michigan it's once a year. I don't know what the improvements are in terms of automatic eligibility.
Okay.
But that's something that an enrollment person at your local health department would certainly know. Yeah.
Just go right behind her. My question was about provider taxes. If you could speak to how much currently Michigan is leveraging provider taxes to support the Medicaid program?
I don't know what that dollar amount is, do you?
I don't either, not off the top of my head. I can find out if you want to give me your information. Just wherever, Tony.
Okay. The prognosis for rural hospitals, particularly in northern, southern, and then the upper peninsula, is your department or anything in Michigan doing anything to support those hospitals before they give up, their breast?
Well, that's not, we're not doing, I'm trying to think, I mean, like Michigan Health and Hospital Association. I know Michigan State has a rural health center, as does Central just started. So there are departments or within universities that are specifically looking at some of the issues related to, the critical care of rural hospitals.
Yeah, it just seems like those areas are socially invisible, or economically.
Yeah, oh, for sure. Yeah, 100%. Yeah.
Work requirements are often sound reasonable. What would be your estimate as to the percentage of current recipients would be capable medically of actually working?
So I think the issue with work requirements, so I can't answer your question. I don't know if you can, I can't answer that. I think the issue with work requirements is that it really goes to the basic purpose of Medicaid. The purpose of Medicaid is to ensure that people have health insurance coverage so that they can stay healthy or get healthier. And I think that work requirements were so controversial because they do have appeal, I think, to a lot of people. But I think that enrollment in Medicaid being tied to employment is as controversial on Medicaid side as it is for most of us who get our employment, our insurance through our employers, which is, we don't want our insurance to be vulnerable to a change in our employment status. But I think that the court, there was a lot of court ruling around this, so there are just a few states that tried this, Arkansas, Kentucky, and we had a provision in our Medicaid Healthy Michigan plan as well. But the states that did implement it, people fell off the rolls left and right. Lots and lots of people lost their Medicaid coverage. And I think the courts said, because the purpose of Medicaid isn't about employment, it's about health insurance coverage, that this is not a tie that can be made. There wasn't a lot of time to develop data. I think it only was in place in Arkansas and Kentucky less than a year or so. So there isn't a lot of data associated with it, except that very, very early experience was that tons of people lost Medicaid coverage.
Yeah, and I'll just add, going back to the administrative, that idea of churn, people also, not because of eligibility, but because of the requirements, to provide documentation and do it so in time. So there's also that question. Also, I'll add from the administrative standpoint, it's very costly and burdensome at the state level to implement that, because you have to ramp up your systems, you have to have staff to do this. It's not just a simple matter of, yes, no, okay, there's a whole process. So, if that returns, it'll be interesting to see what the evidence, ends up looking like.
Thank you for your informative presentation. Your slide about federal minimum services, did I understand correctly that they do require preventative care for mental health? And if that's true, what does that look like?
Yeah, so preventive care for kids, that early and periodic screening that was kind of at the bottom of that slide. Preventive care for adults is a whole different ball of wax, but preventive care for kids. And preventive care in terms of mental health is a really interesting concept and a little bit hard to get our heads around. But it really has to do with supporting a child and the people who are caring for that child to try to ensure a healthy environment that they live in. So it can be a little bit on the edges of what we think of as traditional health care. So it can be related to family dynamics and housing stability and food stability and things like that. And but it's such a great question about what does it mean to try to prevent mental health problems.
Time for one more question.
Hi, you mentioned the FMAP and that Michigan is a 65-35 approximately federal reimbursement and that other states vary differently and that some services are reimbursed at different rates. Can you speak to me about who determines those rates and how those are set?
So services are so that goes to the provider level of reimbursement. I don't know that, I'm not expert on provider reimbursement. I think that's set within the legislature.
So it really depends, I think. I think the easiest way to think about it is people who qualify for Medicaid who are enrolled in a Medicaid health plan, the actual health plan contracts with providers. So Aetna contracts with Michigan Medicine and says, here's how much when our people who are enrolled with us, they're in the Medicaid program, but they're enrolled with Aetna or Blue Cross Complete or Molina or Meridian, or I can't think of all of them. And that health plan gets a certain amount of money from the state to cover those people. And then the health plan contracts with hospitals, with dentists, with, they put together a network of providers who are covered. And so the terms of the contract are not public. The department,
So I was thinking like the actual state, federal reimbursement, like who determines why does Michigan get 65% as the federal?
It has to do with how wealthy we are as a state. So Connecticut only gets 50% because they're rich. And Mississippi gets 80% because they're poor. So it really has to do with the income levels in our state.
Well, let's take a moment to thank Tyler, Melissa, and Nancy for great information. Just so you know, this PowerPoint will be up on IPPSR's website in the next day or two. And one more announcement for those of you from legislative offices. We're again partnering with James Madison College on our Rosenthal intern program. And the first intern program will be here in this room on January the 23rd. So if you're with the legislative office, look for those notices. Thank you very much. Join us again on February 4th for our next forum.